at ESMO 2022, we presented an update from ADAPT and ADAPTcycle. And ADAPT is a trial that we had published already in JCO in 2022 by Nitzet et al. And what we done in ADAPT was to take a three-week period before surgery in luminal early breast cancer to give patients endocrine therapy. And then we looked in the surgical specimen for a drop in Ki67. And if Ki67, the proliferation marker, was 10% or less in the surgical specimen, we called that endocrine response. And that was analogous to data presented earlier by Mitch Dowsett and his colleagues from the UK, or Matt Alice from the US. So very robust biomarker. And in ADAPT, we found that if we combine this with Oncotype DX, we're able to withhold chemotherapy safely in pre- and post-menopausal patients with up to 3 involved lymph nodes, Oncotype up to 25, recurrence score, and endocrine response. For example, the young women in ADAPT after 5 years had a distant disease-free survival of 97%. So with endocrine therapy alone, postmenopausal patients, 95% with endocrine therapy alone. So no need for chemotherapy. So what we did at ESMO was we looked at the endocrine response rates in ADAPT and compared them to the endocrine response rates we saw in the first 2,500 patients in ADAPTcycle, which is the follow-up trial in which asked the question whether we can replace chemotherapy in early luminal breast cancer by an endocrine-based approach with ribociclib as a CDK4/6 inhibitor. So again, we have endocrine response rates. And what we saw was, first of all, that we have concordant endocrine response rates in the postmenopausal patients. So in ADAPT, the endocrine response rates with AI in postmenopausal women was 81%, in ADAPTcycle was 78%. So very similar endocrine response rates in the postmenopausal population. And then the premenopausal population as well. If we have tamoxifen as a sole agent, we only have 40% endocrine response overall in the ADAPT study. And then ADAPTcycle it was 2%, so very robust biomarker. But the interesting thing in ADAPTcycle was that we saw that if we add GnRH to the short preoperative endocrine therapy, we get response rates in the vicinity of what we see in the postmenopausal patients. So about 77% with GnRH and AI, and about 60% with GnRH and tamoxifen. So with optimal endocrine therapy, we have about the same response rates in young women than we have in the older population. And taken together with the findings we saw in ADAPT, I think it's very safe that we can conclude that we could use endocrine response as an additional biomarker, for example, to a gene expression assay to first of all see how patients respond to endocrine therapy, but then also withhold chemotherapy in those patients with a recurrence score up to 25 and good endocrine response. And the last result we saw was that in the ADAPT population, endocrine response is a prognostic factor by itself. And interestingly, its impact on outcome is greatest in the young women. So I think that is a very important biomarker, and we should all now try to incorporate that in our daily clinical practice.